Dr. Sreedevi here, working as an HOD Hematology at Vijaya Diagnostics, Himayatnagar. And today we would like to present a topic. It's a general topic like anemias in general conditions. So which is usually come across by every patient. So today our presentation would be done by Dr. Asima Quadri, who is a senior consultant at our hematology department, has been working for since 8 years at our Vijaya Diagnostics. Now on to Dr. Asima for your presentation.
Thank you so much, ma'am, for introduction. Now, directly, I would go to the topic of today, and that is an approach to anemia general considerations. So, let me quickly go through the objectives. I will start with the objectives, the definition of anemia. And then later we'll go to the classification, the causes, the symptoms, the lab investigations, and finally the treatment. So first, the definition of anemia. Anemia is defined as the reduction of the concentration of circulating hemoglobin or oxygen carrying capacity of blood below the level that is expected for healthy persons of same age and in the same environment. So according to the WHO criteria, anemia is defined as hemoglobin lower than 12 grams in women and less than 13 in men. But the reference values for red cells and hemoglobin as well as the hematocrit may differ according to the sex and age, the race, the altitude, and the socio-economical changes also. Now, the important causes of anemia in India. The first and the foremost is the nutritional deficiency, which involves iron, folate, and also vitamin B12. Then infections involve malaria, which is most common, and hookworm infection and AIDS also. But Kala Azar, it is mostly eradicated, but it is there present still in 4 of the states of India. Then we go to the inherited anemias, that is the thalassemia, the sickle cell disease, the glucose 6-phosphate dehydrogenase deficiency, and the blood loss, which mostly involves the obstetrical problems. Now, the classification, we have 2 classifications. One is based on the morphology, and the second classification is based on the underlying mechanism. So the normocytic normochromic anemia will have an NCV ranging from 80 to 100 femtoliters. The macrocytic anemia has an NCV of more than 100, and the microcytic anemia will have an NCV of less than 80 femtoliters. The classification of anemia based on the mechanism is through blood loss, the decreased production of RBC, and then also the increased RBC destruction. So now we go to the etiological classification of anemia. So we'll go through the important ones. The first anemias are due to the impaired red cell production, and it involves the most common anemias due to deficiency of nutrients, the iron deficiency anemia. In the iron deficiency anemia, we usually see it may be due to nutritional deficiency, or it may be due to GI causes like we have Meckel's diverticulum, and peptic ulcers, and things like that. And we also have due to kidney involvement. Then we go to the megaloblastic anemia, and mostly this is due to deficiency of either vitamin B12 or folate. Then we go to the anemia of chronic disease. So anemia of chronic disease, usually it is due to 3 things. That is, it can maybe due to infection, it may be due to inflammation, or it may be due to any involvement of malignancy. Then we go to the third type of important anemia, that is sideroblastic anemia. In this, we see a defective heme production, wherein the iron cannot enter the heme. Thus, it accumulates in the cytoplasm around in mitochondria. So we generally see this in the form of sideroblast in the bone marrow. Then the aplastic anemia and related disorders. In this aplastic anemia, generally in the periphery, we see the pancytopenias. And in the bone marrows, there's less than 25% of red blood cells. Then we go to the anemia of chronic renal disease. Here also, due to involvement of renal kidney, then there may be disorders of erythropoietin production. Then the rest, also we have anemia of liver disease, then endocrine disorders involving anemia, then myelothysic anemia. In myelothysic, we see the replacement of marrow by either carcinomas, leukemias, lymphomas, infections, etc. Even the storage disorders. Then the final thing in the impaired red cell production is the congenital dyserythropoietic anemia. Then we go to the anemia due to excessive red blood cell destruction, that is the hemolytic anemias. And these can be divided based on the problems with the red cells, which is intrinsic to the red cells as well as which are extrinsic. Then in the intrinsic problems of the red cells, we have defects in the red cell membrane. Here, most general of them are the hereditary spherocytosis and hereditary erythrocytosis. And most of us know that this is due to the defects in the cell membrane proteins, the red cell membrane proteins, that is ankyrin and spectrin. Then the defects in hemoglobin. So it may be either quantitative or qualitative. So what do we mean by quantitative and qualitative is, in thalassemias, we have defects in the production of beta globin chains, wherein there is a defective production. So the quantity is decreased. Whereas in sickle cell disease and other variant hemoglobins, the abnormality is in the quality. Due to the gene defect, for example, in sickle cell anemia, we have the glutamate replaced by valine. So here there's a qualitative defect. Then we have other problems like defects in enzymes. The most common is the glucose 6-phosphate dehydrogenase deficiency. And here we know that during any oxidative stress, there is hemolysis. Now we go to the extrinsic problems of the red cells. The common is the immune hemolytic anemias. The causes may be autoimmune, alloimmune, or drug-induced. So generally in autoimmune hemolytic anemia, it may be warm type, whereas and also cold type. And in warm type, that is mainly seen in the room temperature, it is mostly IgM type, whereas, IgG type, and then the cold agglutinin. That is mostly IgG type. And whenever there is exposure to cold, we see the agglutination of RBCs. Then the second important abnormality of extrinsic to the red cells is the mechanical hemolytic anemias. Common to them is microangiopathic, involving the it can involve either ITP, that is or TTP, sorry. And then there are some the final the third thing is the anemia, which caused by physical, chemical, or the infectious agent. Finally, we go to the hypersplenism, in which we see due to enlargement of the spleen, there may be excessive pooling and destruction. Going to the symptoms, most of the symptoms we are familiar with, like we generally, the anemic patients, they have easy fatigability, loss of energy, tachycardias, shortness of breath, headache, etc. All these are symptoms we come across. We go to the basic approach to diagnosis of anemia, the basic investigations. To start with, we have the hemogram, or the complete blood count. For us at Vijaya, we are doing a hemogram and including retic count. So generally, in the CBCs or hemogram, if low hemoglobin is there, then we go in for abnormalities restricted to the red cell series or white cells and platelets. So if it is red cell series, then the first important point will be the reticulocyte count. If it is raised, then we know that it is a blood loss or the hemolytic anemia. If the retic is not raised, then appropriate to the degree of anemia, then we look into the red cell index. Like if MCV is low, then it is microcytic. If it is normal, then it is normocytic. And in cases of bigger sized RBCs where MCV is high, we go in for macrocytic anemia. In cases of abnormalities of white cells and platelets, if they are associated, then directly we can go in for the bone marrow examination. So the normocytic anemia, first we go through this based on the retic count. If it is increased, then we know that it is hemolytic anemia. And then if it is normal or low, there may be underlying chronic disease like any renal failure, etc. So if there is no underlying disease, then directly we can go in for the bone marrow examination. And if there is underlying renal disease, any disease, then we can evaluate for the disease. Then for bone marrow, if it is normal, then it can be anemia of chronic renal failure or it can be anemia of any chronic disease. Whereas in cases of abnormal presentation of the bone marrow, it can be aplastic anemia, ineffective erythropoiesis, and myelothysic. As we have already discussed in myelothysic, the bone marrow is replaced by either lymphoma, leukemias, or carcinomas. So these are the NRBCs usually we come account along with polychromasia in the peripheral blood of hemolytic patients. And here it is the reticulocyte supravital staining. So now for the evaluation of the microcytic hypochromic anemias, usually MCV is less than 80 as already discussed. Then we go in for the serum ferritin levels. If they are low, obviously it will be iron deficiency anemia. And if it is normal, then we go for hemoglobin electrophoresis. If it is high, then serum ferritin is usually high in anemia of chronic. So in case of hemoglobin electrophoresis, if it is abnormal, then it can be any variant like thalassemia. And if hemoglobin electrophoresis is normal, again we have to check in for any disease, or it can also be sideroblastic anemia. The macrocytic anemias, again the importance of retic count. If it is increased, then it may be hemolytic anemia or it may be due to blood loss. Then if retic count is normal or low, then it can be any involvement of the liver or the drug involvement may be there in hypothyroidism also we see a normal or a low count. Then suppose we are not seeing all this, then we have to go in for the bone marrow examination. So if it is a normoblastic picture, we can think of liver disease or hypothyroidism. And then if there is a megaloblastic involvement, like we see distinct features in the bone marrow in the form of giant bands, then megaloblasts, and we see dyspoetic features. So then all these, if the features are there in the bone marrow, then we can think of folate and vitamin B12 deficiency. Then we can see dyspoetic features also in myelodysplasia. Therein also MCV is high. So, and then in case the bone marrow is hypocellular, then definitely we ought to think for aplastic anemia. So to differentiate between cobalamin deficiency, that is B12 and folate, all these are the findings, and we also have methylmalonic acid, which is increased in cobalamin, that is B12 deficiency, and we also have at our lab. Going into the features, laboratory features which are suggesting a hemolytic picture that is based on the peripheral smear. So we can identify so many different cells on the blood smear indicating different etiologies. Like for example, if we find spirocytes, and then we go in for the DAT test, that is direct autohemoglobin Coombs test. And then if it is positive, then we can think of autoimmune hemolytic anemia. If it is negative, then it can be hereditary spherocytosis. In this, obviously, we go in for the tests like OFT, etc. Then the cystocytes, the most important cells, and they are also according to the ICTH guidelines. They are given special importance, and even less than 1%, if we are finding in the peripheral smear, they are important, especially in kids. And if we see cystocytes, it indicates microangiopathic hemolytic anemia, which involves TTPs, hemolytic uremic syndrome, and DIC. Then on the smear, if we have microcytic hypochromic picture, and we also have hemolytic things like maybe NR bases or target cells, then we can think of thalassemia. Then if we find sickle cells, it can be a sickle cell variant, which we generally these two we can do by HP electrophoresis or HPLC. We do HPLC at our lab. Then in G6PD deficiency, we have white cells. So white cells, etc. All these are, how are they formed? Now what happens in the spleen or liver? These macrophages, they start biting the spherocytes and then abnormal cells, so that we see white cells in the peripheral smear. So in case we find normal red cells, we can suspect of PNH, G6PD deficiency, or unstable hemoglobin disease. PNH is paroxysmal nocturnal hemoglobinuria. In this, again, there's a membrane disorder wherein it can be either directly the membrane involvement, wherein the flare is the test wherein it detects PNH, or it is CD55 and 59 also, which detects the membranes attached to this anchoring protein, cell proteins which are attaching to this anchoring protein. We also have an important parasite, the malarial parasite, which also leads to hemolytic anemia. So for the most important test, like CBC and the hemogram, we have Coulter's, the 9HX900. So it gives all the features, including the retic and the NRBCs. So these are the histograms which we usually check at our Coulter's before we go in for the slide review. So the area between the 60 to the 125 femtoliters is the one wherein the histogram MCV and RDW are calculated. So generally, if there is a shift to the left, it indicates a microcytic picture, and a shift. This is the Coulter at our lab, which is showing a shift to the left, along with the area showing that of polychromatophils. So, and so how to differentiate a microhypo picture with low hemoglobin, and if it is a thal trait. So herein we see that in this we see RBC count to be low, whereas in our practice we usually see that RBC is high in case of thal traits. So in macrocytic anemia, in the peripheral picture, we see a hypersegmented neutrophil here with ovulocytes and macrocytes. And in the histogram, we see a shift to the right. Here's a dimorphic picture wherein it may be due to treatment of with hemagenics or a blood transfusion. Here we see two different morphologies of the RBCs, the normal and the microcytic. So apart from this, we also have HPLC for the variant hemoglobins. So we have Tosho G11 at our place, at our lab. So daily we'll be doing, we have batches, including on Sundays. So this is a chromatogram of a thal trait patient from our lab. So here HbA2 is on the higher side. So, and this is again the same Coulter of the thal trait patient. So we also do a sickle test for a sickle cell anemias. So this also we are having at our lab, wherein the sickle cell anemia cases are done. So finally, the treatment of anemia, and And mostly in iron deficiency anemia is nothing but nutritional, and then prevention also. Prevention mostly is this will be advised with the physician. So in pregnant females and all, this prevention is important. In cases of B12 and folate also, uh, we have to supplement it during pregnancy. This is also something about the prevention of anemia, like the deworming, etc. And then in pregnant females also, we have to have iron and folate. Then WHO advises food fortification also. Thank you. Thank you so much. And now to Sreedevi, over to Sreedevi, madam.
Thank you, Dr. Asima. It was a very good presentation. Actually, on anemia itself is a very vast topic where we have just covered the most basic ones. And if we go into the depth, it's a very vast topic. And I would just like to add little more points to what Dr. Asima has presented. And very wonderful presentation, Dr. Asima. Very
Thank
good.
you.
And regarding now latest ICH's guidelines regarding schistocytes, it says that in an adult and a normal full-term neonate, up to 1 or less than 1% is normal. But and for a preterm baby, it is up to 5% is considered normal. So we have to screen the slide. And here in our cell counters, what we have DXH 900, our RBC indices are all been given, and on the histograms we'll be able to detect. And also on the RDW, depending on the RDW, we get flaggings on the cell counter printouts, the cell counter values. Then depending on that, we make a slides and then review the slides. And for example, all hemolytic anemias like hereditary spherocytosis, or hemolytic anemias like extrinsic hemolytic anemias like thrombocytic purpura and hemolytic uremic syndrome, where you see importance to the schistocytes. So for like hereditary spherocytosis, our cell counter gives a very good parameter, which is also an important one. MCHC is very high. When it is more than 36, we make a smear, and that is the most strong indicator, and it's a very useful indicator. And smear is also, of course, it's most diagnostic. And one more, wherever we get like RBC, Role formation, or autoagglutination, our cell counter will give a R flag, where it means that slide has to be reviewed. So we make a slide and review all the slides. And for autoagglutination, it gives a query agglu, means that is called this smear would be having an agglutination, please review, along with an R flag. And one more important thing what we have is a reticulocyte count, which is an automated reticulocyte count. Like our human eye counts, for example, we count per field 100 cells and about 1,000 cells we count. But our instrument autoanalyzer Beckman Coulter, it has got a reagent which will lyse all the RBCs. It will ghosting of RBCs is done, where the hemoglobin is being squeezed out, and it stains with the methylene blue, where the reticulocytes get stained, and then it has been calculated by methylene blue stained, and it's automatically calculated, where it counts per field around 3,600 cells, where a human eye cannot do. So it gives the high accuracy and a good quality and accurate report. So we get everything is automated, which is interfaced and then reviewed and then released. So where we don't need to again screen the slide and again review this, make a stain the slide and buy again special stain. So this time is is not wasted in. So this is how, which is helping us in improving our TAT, where we have all hemograms. For all hemograms, reticulocyte count is included in our VDC centers. And as Asima said, all dimorphic anemias also, our histograms show very good pattern. Like other, of course, other cell counter autoanalyzers also show the similar things. But these are which are the few important things which our Coulter's autoanalyzer is helping us out. So these are the points which I wanted to add, other than apart from what Dr. Asima has presented. And thank you very much. for your presentation, Dr. Asima, and thank you all
Thank you, ma'am.
for
Thank
your
you so
patient
much.
listening. Thank you, Dr. Asima.
Thank you, ma'am.
Okay, thank you.